hear me for sure?
Yes,
Great.
I can hear you.
Sure, ma'am. So, good afternoon, everyone. Welcome to the new webinar in our medical aid series on the topic stillbirth causes, investigations, and prevention. So, let's discuss something about the webinar. The stillbirth is a tragic loss of a fetus at or after 20 weeks of pregnancy. Understanding its causes, conducting through investigation, and implementing preventive measures are crucial in addressing the heartbreaking event. In this webinar, we will discuss the following: the causes, investigation, and prevention. By understanding the causes and conducting through investigations and implementing preventive measures, we can work towards reducing the incidence of stillbirth and supporting effective families. The agenda today is the webinar, of course, and by 5:30 we'll open the session for the Q&A. Our presenter today is Dr. Renu Misra, who is an editor of the newly launched book, which is Ian Donald's Practical Obstetrics Problem 9th edition. She is a senior consultant of obstetrics and gynecology, endoscopic surgery, and IVF, Sitaram Bhartiya Institute of Sciences and Research, Delhi, and Miracles Fertility and IVF, Gurgaon. She is also former additional professor, All India Institute of Medical Sciences, Delhi. She taught undergraduates and postgraduates in India and abroad. Examiner of MBBS, MD, and DNB. Conducts regular CME workshops in Obs and Gynae for postgraduates and practicing gynecologists. Now I request Dr. Renu Misra to please give us a little more, tell us a little more about herself, and then we can then start the session. Ma'am, I'm just adding your slides right now. Just give me a second.
Okay. Okay. Thank you, Ravi. Thank you for the introduction. Good evening, everybody, all those who have joined today's webinar, and thank you, Wolters Kluwer, for giving me this opportunity to interact with all of you. So till the time that we get our slides on board. So like he said, stillbirth is one of the most tragic events that one can face in the life of a parent, for the family, and even the obstetrician. My niece stays in California, and in her first pregnancy, when she was full term, just 2 days before her due date, she had a placental abruption and had an IUD. And she had to have a cesarean because of the placental abruption. But obviously, the baby was dead, and she was inconsolable. So she called me, and she said, "Bua, could the doctors could have they done something, or they acted sooner to save my baby?" And I told her at that point, I said to her that, "Listen, I know that what you have lost is that damage is irreparable, but the obstetrician would have died 100 deaths when she realized that the baby was dead. So it is not easy for anybody, not the parent, but not for the obstetrician. We always say when there is a serious tragedy, a medical event, a tragic event, there's always a second victim, which is a doctor, which is less talked about." So anyway, let's move on to this webinar. Next slide, please. So stillbirths. Next. So worldwide, if you see, this data comes from WHO, nearly 2 million. 1 million is 10 lakhs. So 20 lakhs stillbirths occur every year, which means that one baby dies in utero every 16 seconds. Almost 40% of these stillbirths occur during labor or intrapartum, which are not all, but quite a lot of them are potentially preventable by giving better obstetric care or providing better infrastructure to these mothers and preventing the stillbirth. Next, please. So the incidence or prevalence, I should say, globally is 13.9 per thousand. This is 2019 figure. You know, the figures for something like stillbirth are not very accurate, and they're very difficult to get because not all of these tragic events get reported. And more so in the economically poor countries, these are not reported as well as they are in developed countries. So with these global figures, you see there is so much of disparity. In the Western country, the affluent society in US, UK, it is something like 3 to 4 per thousand. If you look at Indian figures, these figures were from 2017 to 2020, the total stillbirth rate for India was reported as 12.9 per thousand total births. So the prevalence is calculated on the basis of total births, that is live born and stillborn. But this varies in different states from 3.7 to 22.5. So while some states like Kerala, we all know, have a very low maternal mortality, perinatal mortality, stillbirth rate, there are others which have very high incidence of mortality in the baby and the mother. And these are the states where there are problems with infrastructure, with illiteracy, and access to medical care. So looking at these high global figures of stillbirth, WHO launched an action plan which was called Every Newborn Action Plan in 2014 and set out a target of reducing stillbirth rate to 12 or less per thousand by 2030 across the globe. Next, please. Next. There is a little confusion between stillbirth and IUFT. Although these can be used as interchangeable terms, we say stillborn like it's a self-explanatory term. When a baby is born without any signs of life, it's a stillborn. And intrauterine fetal death, we call it IUFD, when a fetus is found to be dead in utero. So it is still not born. It can happen anytime after the age of viability from 20 weeks onwards. So when you find a baby is dead and you diagnose in utero by an ultrasound, by a Doppler, whatever means, but the baby is still in utero, we can call it IUD. But when the baby is born, we say it is a stillborn baby. But there is no consensus on the gestational age at which you define a miscarriage or you draw a line between a miscarriage and an IUD or a stillbirth. If you look at the American guidelines, they take 20 weeks as the cutoff, and any baby which dies in utero after 20 weeks is considered as a fetal death or stillbirth when it is born. Whereas the Royal College of Obs and Gynae UK gives the cutoff for 24 weeks. They also call it late IUFTs, or they're also called third trimester IUFTs. Next, please. If you look at WHO, then WHO, because it is taking the whole, global scenario. So WHO defines stillbirth as a newborn which is born, which is lifeless after 28 weeks of gestation, or if the fetus weighs more than 1,000 grams, where you do not know exactly how many weeks the pregnancy was before the baby died, or the crown heel length is more than 35 centimeters. So these are the criteria set by the WHO to define it as or give the terminology of stillbirth. Stillbirth rate, like I said before, is defined as the number of babies born at 28 weeks or more per 1,000 total births, which includes live and stillbirths. Next, please. Next. So if you look at the risk factors, which patients are more likely to have this tragic event? So there are factors concerning the mother and the fetus, or there can be pregnancy complications. So maternal factors include advanced maternal age, obesity, smoking, alcohol, drugs. So these are all contributory factors. It doesn't mean anybody who is 45 years of age will have a stillbirth, but they certainly, all these factors increase the risk of having a stillborn baby, or a higher degree of pregnancy loss is seen. Among the fetal factors, multiple pregnancy, fetal growth restriction, almost 1/3 babies are found to be growth restricted, which end up in IUD. Prematurity, again, a very common problem where babies may deliver very premature and may not survive. Congenital malformations, infections, though difficult to substantiate and not very common because a lot of them will already have antibodies. So difficult to say that infection is the cause of stillbirth. but they do contribute to the risk of stillbirth. And even male sex. So if there is a choice between male and female, and the pregnancy is very high risk, we normally as an obstetrician want it to be a female baby, because females tend to be genetically stronger babies and actually survive better than the males. Next, please. Pregnancy complications, placenta abruption, RHI's humanization, post-term pregnancies, because post-term, the placenta may start failing because it is destined to work around for 40, 41 weeks. We do not know exactly when it stops, sort of, or the function gets reduced. Gestational diabetes or overt diabetes is a very, very important pregnancy complication or a medical disorder associated with pregnancy, where there is a high risk of stillbirths if the sugars are not controlled in pregnancy. Previous history of stillbirth, again, is a very important history point, which increases the risk of stillbirth in the next pregnancy. Then there could be cord accidents like a cord prolapse, or there could be a true knot, which is cutting off the blood supply to the baby. Medical disorders like I said, diabetes, hypertension, severe preeclampsia, nephritis, SLE, thrombophilias, and cholecystitis of pregnancies, all these contribute to stillborn babies. Next, please. Next. So how do we evaluate a patient who has an IUD? So we first look at history. So in history, like I've already told you, the risk factors. So based on that, the important ones now, we look at history of previous stillbirth, any history of thrombosis in the patient herself or in a family, because that may give us some clue about the thrombophilias, congenital or acquired thrombophilias, which can actually cause either early miscarriages before 20 weeks, or they can cause IUDs. Medical disorders, we just talked, fetal growth restriction, placental. So all these, which I have just told you as risk factors, you need to take a good history and exclude these. Next, please. Next, please. Evaluation, what investigations should be done? So again, some of these risk factors, which I have told you, the medical disorders. So you need to do an HbA1c to look for diabetes. You need to do antiphospholipid antibodies to look for acquired thrombophilias, that is antiphospholipid syndrome. You need to see the blood group, typing, antibody screen. Klehor-Betke screen or Betke test is to look for fetal-maternal hemorrhage. And in many pregnancies, it may not be obvious that there has been a fetal maternal hemorrhage big enough to kill the baby. So this is one test which is recommended if it is available, should be done in all cases. Bile acids, although normally we make an antenatal diagnosis of cholestasis of pregnancy, but if you get a patient who is unbooked where there is no history, no previous testing, and you find this patient comes to you as an emergency with a dead fetus, we do tests like bile acids to exclude cholestasis of pregnancy, liver function, a kidney function test, and serology for all these infections, like I was saying, parvovirus, CMV, rubella, toxo. Generally, they are not recommended routinely, but if you find history in pregnancy which is suggestive of one of these, or you find any changes in the fetus or placenta, then we can do these. Or if you do not have any history, then you may order it in as a battery of tests. You can include these tests also. But like I said, the big problem with these serological testing is that many women may actually have antibodies already, and they sometimes create more confusion than actually give us a diagnosis why the baby died. Next, please. Then comes the examination of the baby and the stillborn baby and the placenta and cord, which are very, very important. So a stillborn baby, even we as an obstetrician, even if we are not trained in fetal medicine, we can do a physical examination and rule out any gross abnormality, should take photographs. If it is ideal that there is somebody who can do a proper autopsy and look for any internal organ or visceral problems. But if you do not have any such person to do an autopsy, or many times the parents, the family does not give you consent for an autopsy, then we can do radiological tests like MRI, ultrasound, X-ray, whatever you have, do whatever you can, at least document and see whether you can find some reason. And of course, a cytogenetic analysis is very important now. We know that in almost 40% babies, we will find some cytogenetic problem. Placenta and cord are also important to examine. Even on gross examination, you might find problems like a velamentous insertion, vasa previa. You might find if the cord may have a true knot. Histology should be done. Cultures again can be taken, though not always positive. But if you have the facility, take cultures. And the placenta and cord should also be sent for cytogenetics. Why we need to do cytogenetic analysis in both? Because there can be mosaicism. That means the cytogenetics of the placenta and the baby may not match. So we ideally need to look at the genetic analysis for both. And in 20 to 30% cases, despite doing all the tests that you can do, if you have good infrastructure and facilities, you will still not find any cause. So 1/3 still go unexplained despite doing all the tests. Next, please. So I wanted to say a few words more about cytogenetic analysis because others, most people know, but there is a little, the understanding for cytogenetic analysis, some people do not understand that well. What is the difference between karyotype, chromosomal microarray? So all these tests that we do now, what is recommended, what is preferred? So number one, like I said, both fetus and placenta need to do cytogenetic analysis. So earlier we used to do karyotype for in the baby. So karyotype is some abnormality we'll find in 6 to 13% of stillborn babies. But karyotype only identifies aneuploidies. That means it will diagnose any problem with chromosomal numerical problems with chromosomes. That means like most common are trisomy 21, 18, 30 and monosomy X. So these are all numerical disorders. Trisomy means that you've got an extra copy of chromosome. Normally you have 2 copies in each chromosome. So you've got an extra chromosome or copy. So trisomy 21, you all know, is Down syndrome. 18 or 13 are less common. So trisomies and monosomies. So karyotype can only diagnose aneuploidies, number one. Number two, karyotype is a cytogenetic analysis which depends on culturing the cells. So whenever we subject any tissue for karyotyping, you first need to grow these cells. And once they start growing, you arrest them in metaphase and then you take pictures and look, then you look at under the microscope. They arrest in metaphase and then you study the chromosomal morphology under the microscope. So the problem here is that in 50% babies, the culture may not grow, particularly if it is a macerated stillbirth. So the longer the time interval between the baby dying and the baby delivering or you taking the sample, the less is the chance that you will be able to find a cytogenetic problem with the chromosomes, or you will find an abnormality in karyotype because the culture does not grow when the cells are dead. Nowadays, if you have the facility, although it is a little bit more expensive, we prefer to do chromosomal microarray analysis. Now, this is a different kind of cytogenetic analysis. This is not something which requires culturing the cells or does not require cells to grow. This is a kind of, this uses a microchip platform to analyze DNA sequencing. Comparing to a normal sequence, you actually try and find out any changes in the DNA sequence. Is there a part of DNA missing, or is there any duplication? That means excess DNA at some point. So the advantage of chromosomal microarray is, number one, it is not culture based. So it can analyze DNA from non-viable tissue also. So people claim that at least 90%, some studies show that even in 100% patients or tissue samples, they can actually give you a report. So one advantage that you can use it on non-viable tissue. That is why for abortus also nowadays we are doing CMA and not karyotyping. Number two, like I said, it can detect, besides aneuploidy, it can detect microdeletions and duplications. So it gives you diagnosis of some additional genetic disorders, which in case of karyotype is limited to aneuploidy. So it can detect a genetic cause in almost 40% of stillborns when you do a microscope array analysis rather than a karyotype. A parental karyotype is required if the fetus shows unbalanced translocation. In such cases, the parents may be having a balanced translocation, which when transmitted to the baby becomes unbalanced. So this is the important part, that chromosomal microarray is a better technique, and I've told you what are the advantages. Next, please. Now, another very practical point is how to take a sample for genetic analysis. Many times residents ask you and they are not clear. So what all samples to be taken? Number first, if the baby is dead but still not in labor, or there is no such emergency that you need to, like in placental abruption, you will do a cesarean immediately because the mother can bleed or mother can have problem. But in other cases, if the patient is not in labor, you can do amniocentesis and get the sample from the amniotic fluid. The other samples you can take is a placental block, which is taken about 1 centimeter just below the cord insertion. Or you can take an umbilical cord segment about 1.5 centimeters. So this is from placenta and cord. Now, once the baby is delivered, you don't have amniocentesis is not possible in all, because they may come to you in labor, or you may not have the facility to do an amniocentesis. So anyway, if you have a baby now which is delivered, which is stillborn baby, then comes the question of which fetal tissue you should take to do a cytogenetic analysis. So earlier people did fetal skin biopsy, which is very simple. You just take a part of the fetal skin and send it. But now we know that fetal skin is a poor tissue, because as soon as some maceration sets in, why does maceration set in? Because that part of the tissue is not getting proper oxygenation. So the skin biopsy will not yield good results. So now the recommendation is that you should take biopsy from areas which already have or which already thrive on low oxygen. So costochondral junction, patella, these already are used to very low oxygen supply. So they do not show changes due to maceration so soon, and you can actually get a cytogenetic analysis report from these tissues. So fetal skin can be done, but not the preferred sample now. How do you send the sample? Place the sample in a sterile container in ringer lactate at room temperature. Do not put formalin or alcohol, because with that you cannot do a cytogenetic analysis. It fixes the tissues. Next, please. So the patient presents to you with IUD. What do? You take history, you confirm IUD. This is also very important for medico-legal purposes also. You must have at least 2 people do an ultrasound and document that the fetal heart is seen, but there is no pulsation. So confirm IUD, and then of course you send investigations. These are the most important investigations that you send. You send CBC, HbA1c, KFT, LFT, PT, PTT, Kleehor-Betke, and for antiphospholipid syndrome. Give anti-D as appropriate. Kleehor-Betke also helps us. Kleehor-Betke helps us even in a non-RH to know whether there is a fetal-maternal hemorrhage of a significant size. But in RH negative, it also helps us to decide whether she needs extra anti-D. Because if there's a large amount of hemorrhage, then the usual 300 micrograms of the anti-D that we give routinely is not enough to prevent isoimmunization. So Kleehor-Betke is required. Now the question is that if a patient is in labor, then fine, or if you are inducing her immediately, then it is okay. But there is actually no hurry, if patient has, I will just come to reasons where you have to do urgent delivery. But if there is no urgency, you can actually let the patient go home and settle down and call her back. Although most people do not want to do it, they want the baby to be out. That's the usual sort of mental makeup, at least in Indian patients. But suppose she goes for expectant management, then you need to do a CBC, PT, PTT, and fibrinogen twice weekly to look for any changes which may, go sort of, not that you will have suddenly DIC, but if there are any alterations moving towards DIC, then you can intercept at that point. Next, please. Next. So now about terminating pregnancy. Once you have done all this, more than 90% women will deliver spontaneously with a stillbirth, with a IUD. But like I said, most women, most families insist on immediate induction and do not want to wait. What are the problems of delayed delivery, if any? So if the membranes are already ruptured, then you can have intrauterine infection and chorioamnitis, or there is a risk of DIC. But the risk of DIC is overhyped. Usually DIC with a dead fetus in utero does not happen before 4 weeks, or the incidence is very low. And like I said, if you're keeping somebody in expectant management, then all you need to do is to do a CBC and a clotting screen once or twice weekly to make sure that nothing is happening there. Who needs an urgent delivery? Urgent delivery is required if there is obvious sepsis, if there is abruption, antepartum hemorrhage where you cannot let the mother bleed, or there is severe preeclampsia, because severe preeclampsia is a disease which affects the whole body and can have complications which may be renal shutdown and so many others. So this is where you need to deliver, not for the fetal sake, but even for mother's sake, you need to deliver soon. Next, please. So how do we terminate? It is almost always vaginal delivery that we are aiming at. Very rarely you do cesarean in patients like somebody having mass bleeding profusely or placental abruption. Otherwise, most of the time the delivery is conducted vaginally. You can induce labor if there is no previous cesarean. And usually the protocol, although you will find variations in protocols in different books. So this I picked up from FIGO 2023 guidelines. So mifepristone is given 1 to 2 days before, 200 milligrams, 1 tablet. So you can also give only misoprostol, but it was seen that if you give mifepristone before starting misoprostol, then mifepristone is antiprogesterone. So it actually makes the job of misoprostol easier. It makes the uterus more receptive to misoprostol to initiate uterine contractions. So doses of, as the pregnancy advances, the dose of misoprostol is less. So every 3 hours, every 4 hours, some even Royal College UK guidelines say every 6 hours. What you need to understand is that the dose is less as the pregnancy advances, and still this has to be done under constant supervision. If sometime you feel that the uterus is getting too many contractions or going into sort of hyperstimulation, then you need to withhold the next dose. Although there is no risk of the fetus otherwise, but for the maternal sake, you do not want her to be hyperstimulating. Next, please. Next. Okay. No, right. So if there is a scarred uterus, if there is a previous cesarean section, then it is very well accepted that prostaglandins, all prostaglandins, including misoprostol that we use most often now for inducing labor, will increase the risk of rupture uterus. How much does the rupture risk increase? Usually the figures mentioned are 3 to 12% increase. But the point is that it's, even if it is one patient, it is very difficult, I mean, so statistics is one thing, but having one such event in one obstetrician's life is enough, to uh, difficult for her to handle. So we normally do not prefer to give misoprostol to previous cesarean sections unless we are forced to in some cases. So what do we do in patients with previous cesarean? It is better to use a Foley's catheter for ripening the uterus. If the cervix is already favorable and ripe, then you can go ahead and do rupture membrane, do amniotomy and start oxytocin. But suppose the cervix is not favorable, then you can give, alternatively, you can use mifepristone. So this is an NHS guideline which says that you can use, normally we give mifepristone 200 milligram. That's a very standard dose. But in these cases, you can use mifepristone 600 milligrams on day 1, repeat on day 2, followed by cervical balloon dilatation, or if that doesn't work, then you can even give misoprostol 50 micrograms 6 hourly. So this is what we can uh, use for inducing labor in previously scarred uterus. Next, please. After delivery, I've already told you about the fetus and placenta. So you need to look at all these things and document very well in your case notes. Documentation is very, very important. You may have done everything, but if you do not document in your file, and if tomorrow something happens and you need to go to court, nobody will accept verbally that you did all this. So everything has to be in black and white. Whatever is written in the file is considered done. Next, please. What about pregnancy following stillbirth? This is also a major problem, that once somebody has had a stillbirth in the previous pregnancy, then obviously in the next pregnancy, the patient herself, the family, and the obstetrician, everybody is scared. Everybody is scared that this should not happen again. There is some risk of recurrence, but nobody wants that this should happen. And at any cost, you want to give a live baby to this couple. So what can we do as medical personnel? So you address the modifiable factors like weight, smoking. So these are something that you can work before the patient gets pregnant again. Optimize medical conditions and medication. Again, this should be done ideally pre-pregnancy counseling. That one, suppose she is diabetic, then her sugar should be controlled. If she is, suppose, let's say she's epileptic, then put her on medication which is safest for pregnancy and optimize the dose. So all this should ideally be done before pregnancy. But if she does not come before pregnancy, then as soon as she comes in the beginning, early pregnancy, then you do all these things. So for medical disorders, you need a multidisciplinary team which can handle all these conditions and get the mother to be in the best condition to continue pregnancy. As obstetricians, our job is to monitor this pregnancy and this baby. So when we're monitoring, we monitor, of course, we do all that we do for any pregnancy. We're looking for chromosomal anomalies, whatever double, triple test, you do NIPT, you do level 2 scan, level 1 scan. Then you monitor growth to look for any fetal growth restriction. Of course, if a patient has had fetal growth restriction in previous pregnancy when there was IUD, then you are even more vigilant. But even otherwise, fetal growth retarded babies are more prone to die. So you monitor growth, and then towards later in pregnancy, you start monitoring the fetal heart with NSTs. You start doing Dopplers. You start doing ultrasound for like biophysical scoring and Dopplers to make sure that there is enough flow, that there is no indication that the flow is going into a brain sparing, that the blood is being diverted to the brain of the baby rather than the placenta. So this fetal surveillance, when should it begin? Ideally, you can start in third trimester, but usually we start 2 weeks before the IUD. So it depends how soon. Number one is when the fetal death occurred, and number two, we start doing fetal monitoring at the point where you feel you can intervene. So suppose a patient is at 24 weeks we normally don't start doing NSTs and Dopplers and fetal and biophysical scoring because we are not ready to deliver the patient at that point of time, because the baby might just die of extreme prematurity. So whenever you're doing fetal monitoring, you have to ask yourself, am I prepared to deliver this baby? So only then it makes sense to start monitoring when you are prepared to deliver the baby, if that monitoring test comes back as positive or shows some fetal compromise. So, but of course, it is very, very important that these pregnancies are monitored very closely. Delivery can be planned between 37 to 39 weeks. Again, this is not a blanket rule. Deliveries will have to be planned depending on whether there is a medical problem, why patient is likely to or had IUD. Uh, I mean, what if there was, if it was unexplained, then maybe you just monitor the pregnancy, keep monitoring the fetal heart and growth, and then deliver at 37 to 39 weeks. But if you did find a cause, then of course you are going to deliver the baby accordingly. So it may have to be much earlier than 37, but certainly somebody who's had a stillbirth, we do not like to go more than 39 weeks, because you're not gaining anything by going more than for 39 weeks, because you've got a mature fetus and you don't want to be increasing the risk of a stillbirth. There is a little increase in respiratory morbidity the earlier you induce or deliver the patient, but again, you have to sort of see the risk benefit of inducing or delivering the baby. Is the risk of IUD more, or the risk of respiratory morbidity is more? So that is how we plan. Next, please. So to conclude, well, it is a very devastating event for parents, family, and obstetrician. Like I said, investigations are needed for counseling, because if you find a cause, it is easier for the parents to come to terms that they have lost a baby. So suppose they come to know that there was genetic disorder, then the grief becomes less, because nobody wants an abnormal baby. So it is important from the point of view of counseling, and then important to prevent a recurrence. Antenatal care must be planned accordingly, depending whether you have found a cause, then you do accordingly. And like I said, if it was unexplained, then you're simply monitoring for growth and fetal heart changes, blood flow changes by Doppler, to see that the baby is growing well and is well nourished with blood supply. And fetal monitoring, antepartum and intrapartum, to prevent another mishap, of course. So with this, I conclude. Next, please. And this is what we all want as doctors, as parents. That's all we want, is to have a happy child, um, you know, which brings so much happiness to the whole family. And of course, the obstetrician. Thank you very much.
Thank you, ma'am. Thank you so much, for this interesting topic. And I believe, this prolonged, pregnancy and stillbirth is one of the very major topic in your book that we have recently released. Ma'am, I just want to reiterate that, recently, we have presented this book, and in fact, showcased this book in the latest AICOG conference, which was in Mumbai. And we have got very good response. And I would say that, there are still some, like, I would like to, if you may allow me to share that, because there are few questions that were asked regarding the book. I believe the book has some many new features, but there are still people who wanted to know more about the this a few of the topics that we have added in our recent edition of the book, which is,
Yeah.
I'll showcase you. Sure, just give me a second.
Okay. Go ahead.
Yeah, I'm just opening. Yeah. So, ma'am, when we showcase this in the AICUG conference, as I mentioned, a very good response. But yes, there are people who wanted to know more about the product in terms of, if I go to the the key features of the product. If you see here that like when you mention about the each chapter, now there are key features and some updated guidance which are given, like for each chapter reflect the latest advances in obstetric care, focusing on practical solutions for common and critical solutions. But when we discuss about what is new in this chapter added in pregnancy following assisted reproductive techniques, what is that? There were some questions about that.
That you have to read the chapter. All chapters are revised to meet 2025. So you can't
Okay.
enumerate what are the changes. Can we have any questions first? If
Sure,
anybody
ma'am.
has any question.
I'm not any questions so far.
All right. Okay. So basically, key features means every chapter is revised, and the only new feature or new chapters that have been added, I can comment on that, that we've added a chapter on laparoscopy because now, although it is not very common to have surgery during pregnancy, but then it does happen once in a while that you have to do surgery. And now instead of open surgery, we're going ahead with laparoscopy. So there are some precautions that need to be taken specifically because the patient is pregnant. So we've added a chapter on that. Then the other chapter that is new is ART pregnancy, because again, we are now delivering so many babies after IVF, and everybody has a question that how does an ART pregnancy differ from a normal spontaneous pregnancy? Do we need to do anything different? Do we need to look, I mean, look for anything, any specific problems because of the hormones she's received, because of the treatment she's received? So these are the new chapters that we've added.
Great, ma'am. Great. So yes, I think that the book is now available. I think on all, I think most of the all campus bookshop as well as the e-com channels. So I hope that new edition, I think, should be quite excited, and and all the students should be quite excited to get hold of the book. And just to mention that although we have the complete book as a PDF is available on our platform, but also we have introduced a new platform called Lippincott Medical Education, wherein we are providing, it's a B2B platform so far, but yes, this book would be available very soon to the institutions as a EPUB version of the book. Like people can scroll, people can take notes, people can share the notes with their peers and all. So the book is available as well as the print as well as the e versions of it. So that I
Is it
wanted to
available on Amazon?
Yes, ma'am. Certainly, yes. I think we have got very good traction also over there.
No, because I checked, I think day before, then it was still showing the 8th edition.
Oh, ma'am, I think I think it's very much there, ma'am. Uh,
Ninth
you have
edition.
to,
I did not see ninth edition.
ma'am, no, it's very much there. In fact, we have got very good traction over there. In fact,
Okay.
so I think it's doing promising figures over there. But yes, I think the book was well, received with the audience. Previous edition also were well accepted by the audiences. But I think we hold a very good future for the new edition also as well. And to our
Okay. Thank you.
yes, ma'am. Thank you so much, ma'am. And our audiences, please do provide your feedback on the link that we have provided. And from Wolters Kluwer, we will continue to bring more such topics, interesting topics through our Medical Ed series webinars. Thank you so much, ma'am, for coming.
Thank you. Thank you very much.
Good evening to all. Thank you so much.
Okay. Can I leave?
Sure, ma'am. Sure. Thank you so much, ma'am.
Thank you.